Good evening, everyone. Thank you for joining us tonight. My name is Zori Boozer, and together with Rock Patel, we are co-chairs of LSRS Education Committee. This is the next in our webinar series, and we are excited to have you all tonight because we will be discussing still very heavily debated topic on neuromonitoring in spine surgery, and Rock will introduce our panelists. So we have a survey that we have conducted, and the survey was sent out to everyone asking the question how much they use neuromonitoring in both decompressions alone. And here you can see the results that the majority of participants in the survey do not use neuromonitoring or use it very rarely, and only around 30% or less than % utilizes neuromonitoring in most of the cases. Then when we switch to spinal fusion with or without instrumentation, you can see that around 60% uses neuromonitoring in more than 90% of their cases, and then 28% approximately rarely utilizes neuromonitoring. To further really dive deeper, we were asking just in general when they use neuromonitoring and if they use neuromonitoring for what reasons. And you can really here see a split that around 60% it's primarily for safety, and then the other 40% for medical and legal reasons. And this is really interesting because we have panelists who will discuss from both sides. And then really the last question to tie those previous questions was to see if they have in-house monitoring and if that potentially prevents them from utilizing neuromonitoring. And as you can see, 40% has it and almost 60% does not, but still does not affect the use of neuromonitoring. So with that, I'll turn it over to Rock, who will introduce our panelists tonight.
Yeah, thank you all for joining us today. We are really lucky to have some great panelists. We wanted to get an opinion from a neurosurgeon, an orthopedic surgeon, and of course a lawyer. So representing neurosurgery and not taking the stance of not using neuromonitoring for routine degenerative cases is Don Pelly from Cleveland Clinic. Mike Lee is going to be the orthopedic representative, and he's going to be speaking on behalf of using neuromonitoring for lumbar degen cases. And Paul Hubner is an attorney over here in Ann Arbor for Tenuri, Knotts, McKinney, and Dwayhe. And Paul's been nice enough to give us the legal opinion, because as you saw from the panel, 40% of people use it primarily for medical legal reasons. So I think this is a really salient point. Like Zori mentioned, if you have any questions, please just put them in the Q&A box. And after all the speakers finish our presentations, we can go through the questions and ask the panelists and get their expert opinions. So thank you all for joining. Mike, you want to kick it off?
Yeah, just sharing my screen here. All right, I assume that you all can see that. So neuromonitoring plays an important role in the safety of posterior lumbar decompression and fusion. Just first, thanks to Rock and Zori for inviting me. It's always fun to be part of these things. And I think it's a really interesting topic without consensus. These are my disclosures, not really relevant to the topic at hand. So when we talk about neuromonitoring and lumbar spine surgery, we're really kind of talking about EMG monitoring and SFCPs. And when we talk about EMG monitoring, there's two kinds of EMG monitoring. There's a spontaneous EMG monitoring, which is really meant to monitor for excessive manipulation of the nerve roots, kind of pulling, retraction, compression, whatever. And there's no direct electrical stimulation of that nerve root. And we're essentially waiting for neuromonitoring to kind of say something if they see EMG activity as we're doing our procedure. And you contrast this to the triggered EMG monitoring, which is also known as testing screws. Traditionally, this is done with testing the nerve root at 2 milliamps with the probe. And then you test a screw at increasing milliamps. And in general, if it's 5 to 8 milliamps from your control, that's suggestive of a breach. Whereas if you're greater than 15 milliamps, particularly above your control, that is, there's a 98% likelihood that there's no breach there. Sorry. So this isn't foolproof. I mean, it seems like it would be foolproof because it's pretty scientific, but there can be false negatives. And the reasons for false negatives could be if there's parallax on board. So EMG, anesthesia can't have any parallax on board. Proper EMG probe placement on the screw. You know, a lot of our screws are polyaxial. So if you place it on the tulip, it's not really directly on the screw, which may be touching the nerves. We want to make sure that that probe is on the screw itself and not just the tulip. And we also want to make sure there's clearance of other tissue or fluid which may affect the circuit. And finally, if the nerve root is injured, well, you may not get that EMG activity even if you're directly on the nerve root. This kind of highlights the importance of getting a control signal at 2 milliamps on the nerve root, which if you have a decompression ought to be easy enough to do, but sometimes isn't always feasible, for example, in percutaneous screw placement. And in the course of placing pedicle screws safely, there's a lot of different techniques that we have, and neuromonitoring is just one of them. You know, we all know we can just use anatomic landmarks. I'm sure most of us in our open cases palpate with a ball tip probe to feel for a breach inferiorly or medially. We can actually do a laminotomy and feel the pedicle on the outside, the inferior and medial border to ensure, with a Woodson elevator, to make sure there's no breach. We can also use biplanar stem fluoroscopy, or we can use advanced intraoperative imaging, or even robotics and navigation. And of course, neuromonitoring triggered EMG testing is just one modality to check the safety over pedicle screws. So what does the literature say? To summarize, it's really all over the place. You'll find studies supporting this use and not supporting this use. You know, early on, this is a study by Welch and others, over 164 pedicle screws, and they concluded that this technique of using EMG monitoring or and SSCP monitoring may be useful to surgeons early in their implant experience or during particularly technically difficult operations. This is a study out of European Spine Journal, where they looked at lumbosacral surgery and multimodal intraoperative monitoring for 409 patients and 409 surgeries and 409 patients. And they've reported a 90% sensitivity for nerve root injury and a 99.7% specificity. And it's worth noting that this is with spontaneous EMG monitoring. No triggered EMG was done in the study. This is a study by Gunnarsson and Failings, real-time continuous intraoperative electromyographic and somatosensory evoked potential recordings in spinal surgery. Correlation and clinical and electrophysiologic findings in a prospective consecutive series of 213 cases. And what they found in this study is that the EMG was actually 100% sensitive for new neurological deficit, but it was only 23.4% specific. Conversely, SSCPs were 28.6% sensitive, but 94.7% specificity. So by using both, you can kind of get the best of both worlds. And they concluded that neuromonitoring is both helpful in predicting and possibly preventing neurological injury. On the flip side of things, this is a study out of Los Angeles. Zori, who's the co-author on the study. The utility of intraoperative neuromonitoring for lumbar pedicle screws is questionable. A review of 9,957 cases. And what they found here is that the risk of neurological conditions following a post-lateral fusion in the absence of deformity is low. And the routine use of neuromonitoring may not decrease its use. So in those that had monitoring, they found that the risk was 1.36%. Those that didn't have monitoring, the risk of injury is 1.34%. So not a big difference. As you can imagine, with that many cases, we're probably looking at some kind of database study, and this is a Pearl Diver study, which of course is reliant upon codes. Whenever you use codes, you have to be mindful of what those codes are looking at. In this case, when you code for EMG monitoring or when you bill for EMG monitoring, there's no differentiation between spontaneous versus triggered EMG monitoring. So we don't know exactly what kind of monitoring was used. There's another study by Osterman and others using the NIS database. Now, the discussion in the results section is kind of scant, but they concluded that the neuromonitoring use did not impact the likelihood of developing a neurological condition, and they felt there was no meaningful benefit to its application. They felt that most people use it largely for medical, or they imply that most people use it for medical legal implications. And finally, this is a study by out of Baltimore, Tim Witham's group, looking at 2,450 screws, and they use post-operative CT scans to assess for a breach. And they use a pretty specific criteria. There's 5.0 milliamps and higher. And when they tested the screw at 5.0 milliamps, they found that the specificity, oddly enough, was 99.9% of a breach detection. And the sensitivity was low, only 43.4%. But if they increased their milliamps threshold, that sensitivity number went up to 69.6% and so forth. What they concluded was that any screw showing positive stimulation below 5 milliamps warrants immediate intraoperative investigation. Interestingly about this study, they looked at postoperative CT scan breaches as their measure of outcome, and not so much clinical symptoms. And sure, while the breach certainly increased their likelihood of clinical symptoms, they are not necessarily synonymous. So in regard to the literature, there's really no consensus. I'm sure Don will present other literature on both sides of the argument, both sides of the discussion as well. There are studies supporting its use. There are studies not supporting its use. But most studies will agree that this can play a role. Clearly, there is some utility to using neural monitoring in lumbar spine surgery, particularly revision surgery where the anatomy might be obfuscated. Deformity, if there's some kind of more than usual nerve root manipulation or nerve movement. MIS surgery, where maybe you don't have all the other tools at hand, maybe you're not doing a laminotomy and you can't check your pedicle screw safe placement with the usual techniques. And I put an asterisk by this because I'm going to go into this a little more detail later on in this presentation. So basically, neuromonitoring lumbar spine surgery really is a question about safety. Does it enhance the safety of what we do? So I want to ask the question, do we absolutely, unequivocally, 100% need neuromonitoring during lumbar surgery? And I would say that the answer is no, because can we achieve the goals of lumbar spine surgery without neuromonitoring? And I would say the answer is yes. We do have techniques to be able to ensure safety of what we do, and we don't absolutely 100% need neuromonitoring during lumbar spine surgery. But can neuromonitoring play a role in enhancing the safety of spine surgery? And to this question, I would say yes. Yes, neuromonitoring is not perfect, and there's definitely, we need to know how to interpret the signals and be aware of false negatives and false positives. But on the whole, it does have a role in enhancing safety in spine surgery. And when you think about those three questions, do we absolutely need it? Can we achieve the goals of surgery without it? But does it enhance safety? Think about those questions and those answers. And think about, if you take a step back and look at lumbar spine surgery, think about all the things, all the tools we use, all the techniques we use, and what else fits in that category. For example, robotic and navigation guidance in OR. Is this something that we absolutely need to perform lumbar fusion? No, we can certainly do it without it, and we have. But can we achieve the goals of surgery without it? Absolutely. But does it enhance safety? And for some surgeons, the answer might be yes, depending on what their comfort level and familiarity with instrumentation is. What about CM fluoroscopy? Do we absolutely need this? Well, no. We used to use portable X-rays to visualize the spine radiographically. So we know that we can achieve the goals of surgery without it. Does it enhance safety? I would say yes, it does. It definitely makes it faster than waiting for a portable X-ray. And that if you can decrease overtime, that certainly increases the safety of the surgery. But if you take that one step further, do we even need portable X-ray? There was a time when we did these surgeries without portable X-ray. You make a larger incision, you feel the sacrum, you count from the sacrum up to whatever levels you want to be at. You do your laminectomy, you put in your pedicle screws using anatomic landmarks. So theoretically, we don't even need portable X-ray to do our surgeries. We can achieve our goals of surgery without portable X-ray. But no doubt about it, just some kind of radiographic visualization does enhance patient safety. Operative microscope. We know we can do these surgeries without an operative microscope. We can use loops to headlights. That's the way I was trained. But I think you can see a lot more. So I think it does enhance safety, and it does. We can achieve the goals of surgery without the microscope, but certainly it enhances safety in my mind. It also helps my neck feel better, so I don't have to wear all that stuff in my head. And if you think about the specialized tools, everyone does their surgery a little bit differently. Some people use a motorized burr, some people use Kerrisons, some people use a Masonics bone scalpel or Accumantis. And these are all things that we use because in our own hands, in our own preferences, we believe they enhance the safety of the surgery that we're about to do. But we don't absolutely need every single one of these things, and we can certainly achieve our goal of surgery without a lot of the tools that we use. This is a case, well, this is not the exact case, but it's an example of a case. So in my first year of practice, I saw a patient with a far lateral disc herniation. And we all know that after non-operative treatment fails, the surgical treatment flows will be a Wiltsey type approach for a microdiscectomy, where you can see that we go lateral to the facet as opposed to medial to the facet. I'm not going to lie to you, my first year of practice, I was a little bit nervous about this case because honestly, I hadn't seen too many of them. And though I knew what to do, I just wasn't familiar with the anatomy. So upon exposure, and this is lateral to orient you. This is the L4 transverse process. This is the L5 transverse process. And there's facet. Now you can see the nerve here, but before we get down to this point, after you take off the intertransverse membrane, it became a little bit difficult for me because I wasn't 100% sure where that nerve root was. And if I started dissecting, I got into some bleeding, and then, yeah, sure, I used my bipolar cautery to address the bleeding, but I'm a little bit nervous about using bipolar cautery when I'm not 100% sure where the nerve root was. So maybe I use my flow seal or SurgiFlow, then I use a 1x1 padding, kind of pack it in there. But am I jamming my bayonet and padding right onto the nerve root? Because I don't know where it is. I'm not 100% sure. So in this case, my first year of practice, I use EMG monitoring. And what I did is I took that EMG probe and I set it at 2 milliamps, and I kind of hunted for the nerve root. And I found out where I would get EMG activity. So I knew that over here, I wasn't getting any EMG activity. Around this area, I started getting EMG activity, and back here I wouldn't. So I had a rough idea where the nerve was. And with this orientation, this allowed me to dissect a little bit more aggressively with my bipolar cautery. You can see I kind of fried the heck out of the tissue lateral to the nerve root and medial to the nerve root as well. And this allowed me to localize the nerve root and find things, and essentially allowed me to be more safe. Is this an extraordinary case? No, this is not revision. This is not deformity. This is a pretty ordinary case. But in my first year of practice, I wasn't sure of my anatomy. I wasn't sure how much I could really pull on that nerve root. And in this case, the EMG monitoring did help me significantly. So when we think about neuromonitoring, we know that it can play a role in revision cases, deformity cases, and MIS, but I would submit and I would contend that it also plays a role in other cases. Spine surgery is not easy. And at some point, once we get past all the studies and all the data, at some point, medicine and surgery becomes an art. There's a certain comfort level and a familiarity level that we don't necessarily quantify on paper. There's no book that tells you how much tension a nerve can tolerate. There's no YouTube video that can teach me that. The only way you can learn is through experience and repetition and feeling that tactile feedback again and again. Now, if we use other modalities such as neuromonitoring to help us kind of get to that point, I think that's completely fair. I think every surgeon has a different familiarity level, experience level, and comfort level at different kinds of surgery. And the use of neuromonitoring should not be disallowed. And if people want to use it, I think that's absolutely fair game. If you think about this debate, in the United States, neuromonitoring for lumbar spine surgery, payers are starting not to authorize for neuromonitoring use. So there is that side of the how this argument or how this debate is manifesting in real life. But on the flip side, if you don't use neuromonitoring and you have a patient wake up with a neuro deficit, those patients will sue. And I know there's examples of this from just anecdotal feedback from colleagues. So these are real life issues in terms of there's both sides of the spectrum. My conclusion is that neuromonitoring for lumbar spine surgery is one tool of many to optimize the safety. And that tool should be decided at the discretion of the treating surgeon. It should not be a requirement, meaning if someone chooses not to use it, I think that's fine if they're comfortable with that. But it should always be an option. And depending on where you are in your relative comfort level or familiarity level, it should be at the discretion of the surgeon, whether it's revision, MIS, deformity, or just safety. And if that's a question of me, I feel safer with this modality on board, then by all means, I should be allowed to use it. And I think that's at the discretion of the surgeon. So in conclusion, neuromonitoring plays an important role in the safety of posterior lumbar decompression and fusion. Thank you.
Mike, thank you for that great talk. Really appreciate it. I think Dom is going to be up next, and Dom's going to take the counter stance that routine use of neuromonitoring should not be done for lumbar degenerative cases. Thanks, Dom, for joining us.
Can you all hear me?
Yep.
Okay, thanks for having me. I want to thank Rock and Zori and the LSRS and Katie for allowing me to talk today. It truly is my favorite organization, and I'm really happy to be part of it. So let me just share my screen for a moment. Okay, so I am taking the stance that there is no benefit for routine use of intraoperative neuromonitoring in degenerative lumbar spine surgery. No relevant disclosures. So the reasons that intraoperative neuromonitoring is utilized, kind of per the survey, sort of demonstrated this as medical legal, surgeon comfort training. Great talk, by the way, Mike, and some really good points that I agree with a lot of them. And the prevention of neurological injury are all reasons to utilize intraoperative neuromonitoring. Specifically, the prevention of neurological injury and deformity and tumor, when there are cases where we can adjust what we're doing for, for deformity correction and make adjustments to prevent neurological injury. But the goal of intraoperative neuromonitoring is to identify neural irritation and injury at the time when a surgeon can take steps to reduce or reverse it, or define the nature of an injury to proceed with the surgery safely. Those are the goals, right? There's no point in neuromonitoring just to identify that you've made an error, right? You want to be able to, if you've made an error intraoperatively, to go on and fix that error to reduce the amount of morbidity that the patient suffers. So, just because we have a goal doesn't mean we attain that goal. And I think there's a lot of debate between the ability to actually reduce a post-op neurological deficit when you are using intraoperative neuromonitoring, specifically for a lumbar degenerative case. And most of the time we talk about this, we're talking about pedicle screw insertion and medial breaches or inferior breaches of the pedicle screw. Certainly there's benefit in tumor and deformity surgery, but if you look at some of the best studies, there's very low evidence that neuromonitoring reduces the rate of neurological deficits or neurological injury. It can alert you to a neurological injury, but it doesn't mean that it changes it. So I'm going to go through just a few studies. In full disclosure, a lot of the studies on this, like Mike said, they're kind of all over the place, right? And the rate of a neurological injury with a degenerative lumbar case, such as a TLIF, is very, very low, right? So a lot of these studies with a couple hundred patients are significantly underpowered to really tell us anything with granular detail. But just to kind of go through a few, here's a study that looked at cost effectiveness and surgery time in patients undergoing intraoperative neuromonitoring for discectomy. And, of all the patients, 91 of them, none of them had a motor weakness. It's just demonstrated increased operative time and increased operative costs. And I don't know how many of us use neuromonitoring for discectomies. I tend not to, but I think that's probably most common. What about when we start putting in screws? So this is a study of 112 patients, most of them with neuromonitoring, but about 2/3 of them, or 1/3 of them without. And there was no difference in the length of stay. There was no difference in the need for revision surgery between the two groups. It just demonstrated increased cost and increased length of surgery with neuromonitoring. So as we get into some better studies as time has gone on, this is a systematic review of 32 articles. It kind of speaks to, yes, you can pick up a neurological injury if you neuromonitor. You can see if something's happened often, but it doesn't mean that it changes your final outcome. So I'm very interested to hear the last talk on some of the medical legal issues with it. But in my head, I think to myself, well, do I really want to say and document that I've caused a neurological injury that I can't fix, right? Is that a good thing from a medical legal standpoint? I know it feels good and it sounds good to say I neuromonitored, but I don't know when you get down to it, if you can't change it, if it's really what you want to document during surgery. So their recommendation in this article was to be used in cases where the spinal cord or roots are at risk, such as a deformity surgery. And certainly as a group of spine surgeons, we need to develop more evidence-based protocols when and how we should use intraoperative neuromonitoring. So in 2014, the AANS updated their guidelines for performing neuromonitoring in degenerative surgery. And this is the paper in the journal Neurosurgery Spine. And basically, if you get down to it, what they suggested in their guidelines is there's really no evidence that intraoperative neuromonitoring can prevent an injury to a nerve root. There's some evidence that a threshold below 5 milliamps with direct stimulation can indicate a medial pedicle breach. But even if you breach the pedicle or put a screw through a nerve root, inferior or medial, it doesn't mean that you could do anything to fix that after that's done. So it doesn't necessarily alter your outcome. So what are we talking about when we say neuromonitoring? Mike went through this really nicely, probably better than I'm going to. But so we tend to use triggered EMG. And what triggered EMG is we put the pedicle screw in, and then we stimulate the pedicle, and then there's a certain threshold, and we say if it's below that threshold and it's stimulating the nerve root relative to the control, that is a positive response. Traditionally, in the lumbar spine that's less than 10, In the thoracic spine, that's less than 6, but again, there's some evidence that suggests that if you use 5 as your threshold, it's a little bit more sensitive to pick up sensitive and specific to pick up a neurological injury or medial pedicle breach. The problem with triggered EMGs is there's a lot that goes into getting a good reading that sometimes is difficult to do, right? So the anesthesia can be a problem, use of muscle relaxants, any pre-existing nerve damage. So a lot of these patients, they have a problem with the nerves. That's why we're doing surgery in the first place, right? And so it can alter your reading, so you don't know if you're getting a good reading anyway. You got to make sure the field is clear of blood and you're not trying to conduct through blood. And you want to stimulate the screw itself. You can't just put the probe on the tulip and say that's a reading. It's not really a good reading. So there's so much user error that can go into triggered EMG that it's very hard to know, am I getting a good reading? Is this helping me? And in the cases, I in full disclosure, I use very, very little neuromonitoring in my own practice. And I can say when I do use neuromonitoring, it doesn't do anything but increase my stress level. I'm more stressed out when I use neuromonitoring than I am when I'm not. And I think some of the user errors and not knowing if I'm actually getting a good reading back is part of what contributes to that stress. Here's kind of an interesting article I did want to go through that actually, if you look at it on the surface, probably speaks to the other side. But this is a very recent article with a good number of patients, 4,400 patients. And what they looked at is, forget about the triggered EMGs. What if we look at MEPs? And so they demonstrated that they thought EMGs were not very sensitive, with only a 4.3% sensitivity, whereas an MEP, it was 100%. So what they did is they compared it against like the TIB-ANT, and if somebody woke up with a foot drop, if the MEP dropped below 50% threshold, that was considered a positive response. So typically we've all learned as we study for our boards over the years that it's less than, if it drops more than 80%, that's a positive response in your motor evoked potential. They used 50% as a threshold. And of the ones that they couldn't fix, right? So if somebody had a positive change in their MEPs, or they lost MEPs in the nerve root in question, and it didn't change during surgery, all of them woke up with a deficit. So what that sort of tells me on the surface is that, yes, you can identify it and you could be sensitive, perhaps specific, but it doesn't necessarily mean that you could do anything to change it. And I think they demonstrated that pretty clearly. Now, they did have a cohort of patients, around 25 patients in this study, that they did do some things in surgery to change it, and they didn't wake up with deficits. So if they had a resolution of their decreased response, if their MEPs dropped and then they did some things in surgery, and then their MEPs came back, those patients woke up relatively normal or without a new neurologic or progressive neurologic deficit. But what's interesting is if you read the article, right, what did they do to change things? I mean, there's a couple of cases where they redirected a screw fine, but most of it was close a dural tear or release distraction when they're doing a TLIF, or stop, tugging on the nerve root. These are all things that we're going to do anyway. And I think that sort of speaks to the conclusions here, is that I don't think intraoperative neuromonitoring has a role for routinely being performed in degenerative lumbar spine surgery. And I don't know if it's a good thing from a medical legal standpoint to indicate that you caused an injury if you don't have the ability to change it. And I also think that I don't think it should be used as a crutch for poor technique, right? So if they need to do more decompression because they had a change in their MEPs, we should be doing our complete decompressions. We should be palpating the medial borders of the pedicles. We should be ball tip probing our screw tracks, to make sure all that's okay. After the screw's put in and decompression's done, you should be looking at the medial border of the pedicle to make sure there's no screw threads that are there. So I don't think neuromonitoring is good in the sense that it can be used as a crutch, and I don't think it should be used as a crutch, right? I think it shouldn't replace good technique. And I think the corollary there is the O-arm. I use the arm a lot, admittedly, not usually for degenerative cases, but it doesn't mean that I should always just believe what the screen is telling me when I'm using an arm, right? You got to look at your anatomical landmarks and make sure it makes sense where you're putting the pedicle screws in, because there's error in technology. And I think intraoperative neuromonitoring in routine use is the same thing. There's errors in using it routinely, and just relying on it, I think, is a dangerous thing. I think there's a lot of technical issues with triggered EMGs. MEPs are an interesting option, but the overall rate of injury with a standard degenerative lumbar case is so low. I think that I don't think we have a good answer for for whether or not it changes things in spine surgery. And my personal opinion after reading literature is that I don't think routine use will change your rate of neurological injury, which is really what we care about. I do think there's some role for it. I think select cases, if somebody has really small pedicles and it's going to be a difficult surgery to do safely, and it's going to be hard to get in the canal and palpate the medial border of the pedicle, and et cetera, et cetera. There's certainly uses for intraoperative neuromonitoring. I'm not saying it should never be used, but I just don't think it should be used routinely. Thank you.
Thanks so much, Dom, for that talk. Great talk as well. And our last speaker is going to be Paul Hubner, and he's going to give us the legal opinion on the use of neuromonitoring. So thanks for joining us, Paul. I really appreciate it.
Thank you all for having me. I appreciate it. So my position, I'm a litigator for the law firm Tenori, Knotts, McKinney, and Dwayhe, and it's my sincere hope that I never meet any of you professionally. It means that something has gone awry. It means that a patient is unhappy. It means that we have to have some very difficult discussions. That said, the discussion so far it's actually been interesting because it falls exactly in line with what my slides are going to be about. And before we start, I have no conflicts to disclose. So first and foremost, for those of you that have not been involved in a malpractice case, the patient has the burden of proving. The burden of proof, as you may have seen on TV, is that that idea that they have to reach a certain level of proof or evidence to prove their claim. It's a lower burden than in a criminal case because this is a civil case for money damages. So they have to prove it more likely than not that there was a violation of one of these four elements that led to their damages. So if the plaintiff fails at any level, at any one of these elements, to not prove their case within a reasonable degree of medical certainty, or more likely than not is how it's framed, then their claim is dismissed and they get no money. That's it. Today, what I'm going to focus on is really this one, number 2, which flows from the physician-patient relationship that's formed when you as a physician or surgeon take on the care of a patient. The phrase standard of care takes on a special meaning within the medical legal realm. And we're going to delve into that a little bit more because I think that it unfortunately won't provide a full answer for our discussion tonight, but it might inform your personal decisions as you move forward in your practice. So these elements, the first being duty, is a requirement for a medical malpractice case. There has to be a relationship formed between the physician and the patient. It's in fact a prerequisite for the claim to even be brought. The physician in that relationship carries with them the responsibility of informing the patient of all risks, known risks and complications of a procedure, and helping the patient make an informed decision about that process of informed consent. And so in the context of intraoperative neuromonitoring, being able to express to a patient what that neuromonitoring can provide and what it cannot provide, I think is going to be one of the helpful tools that we'll talk about a little later. Ultimately, and this is your burden to bear as surgeons as well, you carry the responsibility within the OR for what happens to your patient. There's a slight nuance when we're talking about neuromonitoring, though, because there is yet another set of eyes or another clinician managing the neuromonitoring aspects of the case, and what duty arises there. This is an unsettled area of the law, which was an interesting fact for me to learn. But the closest corollary I was able to find, at least in Michigan, is for informal consultations, or the so-called curbside consults. The courts in Michigan have likened the second physician there as the eyes for the neuromonitoring as someone who is providing only informal assistance. And so they view it on a spectrum. So as with the literature that Mike and Dominic have shared with us, it's an unsettled area in the law too, as to whether or not there's further physician-patient duty that extends to yet another clinician managing the neuromonitoring aspects of the case. So this is an area I really want to focus on for us tonight. The standard of care really lacks a precise definition within the eyes of the law, but it can really be distilled to the statement you see on the screen here. And if you take nothing away from my discussion with you tonight, I want you to remember this statement here. The standard of care is what a reasonable physician of the same specialty would do or not do under the same circumstances. And that is wholly separate from any guidelines or recommendations that might come from this society or any other. It's different from any protocols, policies, or procedures that are within your hospital system. It's a reasonableness standard. It means that you must do what is reasonable for the patient. And perhaps this will answer Dominic's question about record keeping in terms of using neuromonitoring. Is the standard of care doesn't require perfect care, exemplary care, or even heroic care. It only requires that you do what is reasonable for the patient. So it contemplates a whole range of management options, which could include neuromonitoring. It could exclude neuromonitoring. It depends on the patient, it depends on the circumstances. So the link then is the causation piece. This is the so what for a malpractice case. The breach of a standard of care by itself, aside from being a potential quality of care concern or perhaps a sentinel event within your facility, is legally meaningless unless there is a link between the violation of the standard of care and through causation to their damages. So in the example given of a pedicle screw that's advanced and breaches, if there's no damages, if it doesn't cause any injury, yes, you could say it's a violation of the standard of care to have advanced that screw, that extra torque turn, and caused a breach. But if it doesn't lead to any damages, any sensory deficit, any motor deficit, then that claim must fail because they've failed to show that causation element. And as I point out here, this is often the most difficult element for the plaintiff to prove, particularly in patients with pre-existing deficits or conditions. So the fact that a patient is coming to you for a decompression or fusion tells me as your attorney, hypothetical attorney, that they likely have some significant pre-existing problems that even if there is a surgical misadventure in the operating room, we can defend the case still on this causation piece. Then that final piece is the damages piece. And these are those calculable damages that plaintiffs can show: loss of wages, loss of work, those sorts of things. The non-economic damages, the pain and suffering, the sort of squishy damages, as we call them, those are a little harder to prove. And in some states, they're even capped because of that. In Michigan, they are, which makes Michigan a more favorable jurisdiction for defense attorneys and defendants in malpractice suits. So, as I was saying earlier, the reasonableness standard here, I think, drives at the heart of these two, the pro and con of using intraoperative neuromonitoring. The fact that we have such a split, and I think that our survey from the beginning of this was really, really telling, because it shows this dichotomy within your group alone that says, well, I use it sometimes and I don't. And none of you are violating the standard of care. You're doing what's reasonable for your patients. You have to take each patient as they come, and you have to apply that reasonableness standard to inform your clinical judgment, your clinical decision making. And that is another key phrase that you should remember too, that in your clinical judgment, is it appropriate? Is it reasonable to use neuromonitoring in this patient versus this patient? And as a defense attorney, I can defend that case one way or another, whether you choose to do so or not. It's candidly, I'll tell you, it would be an easier case to defend with neuromonitoring present, because from the plaintiff's side, from the patient side, it shows this extra level of care or thought that you put into monitoring during surgery. And so in the hypothetical that Dominic posited where there's an injury, a recognized injury or recognized complication during a decompression or fusion, and it shows up on the neuromonitoring, that has to be included in the records. And it's one of those, you can't run from the facts. But if at the front end of that discussion with your patient, you discuss with them what the neuromonitoring can do and what it cannot do, it sets those expectations, makes the case, if it ends in a medical legal case, much more defensible. Through my search for this talk today, I was able to find a handful of cases, some of them are directly on point. There are none involving the technical aspects of actually placing EMG or performing the EMG during surgery. And the cases generally fall in these two categories: a failure to monitor and negligent monitoring. The failure to monitor cases, the plaintiff is going to allege that the standard of care required monitoring, and they will have to show through that causation element that the failure to monitor caused the damages to them. There are two cases that really, I think, illustrate this. Kingsley versus Pinto is a case where the plaintiff, Kingsley, awoke with paralysis after a spine surgeon performed an anterior and posterior spinal fusion from T3 to L2 in a single setting without intraoperative monitoring. It was determined that the cause of the paralysis was infarction of the spinal cord. Kingsley alleged that if the monitoring had been used, the complication could have been avoided. The defense maintained that the plaintiff could not identify at which point in the procedure the injury occurred and could not prove that monitoring would have prevented it. The jury returned a defense verdict. So there we see the causation piece of the puzzle in action, that yes, there was an infarction during the surgery, there was a complication or problem, but we cannot precisely show where or when that happened and cannot attribute it to the alleged breach in the standard of care. This next one is a plaintiff case that involves a failure to use monitoring during an anterior cervical corpectomy with a migration of the graft into the spinal cord. It ultimately resulted in a plaintiff verdict of $7.9 million. The expert witnesses in the case testified that if monitoring had been used, the graft dislodgement likely would have been diagnosed and reversed during surgery. So it's, again, fact specific as to the patient and what's appropriate and reasonable for that specific patient. The other bucket of cases that I've seen here are negligent monitoring, that when a waveform change, when there is a signal loss noted within the intraoperative monitoring, what the surgeon did was unreasonable. These are more difficult to prove for the plaintiff. And this is what informs my slight inclination as an attorney to recommend doing intraoperative neuromonitoring, is because the topics that we've talked about, the clinical decision-making, the standard of care being a reasonableness standard, allows for you to explain in a deposition or in your operative note that, yes, we experienced signal loss and there was an injury at this level. The two are unrelated. It allows you to put that right in your note. So when a plaintiff's attorney picks up that chart and looks through, they're faced with those facts in black and white, and their experts are faced with those facts in black and white taken at the time of the operation. And I think that those cases, negligent monitoring cases, will actually peter off and be more difficult to pursue for plaintiffs. So I want to leave you with some best practices, and these are good takeaways, I think, for any physician. But be as descriptive in your operative reports and note your reasoning for using or not using. Like I said, as a defense attorney, I can support either. Experts will support either. But the more descriptive you are in your operative report, saying that this patient is a candidate or this patient is not a candidate for neuromonitoring during surgery for these reasons, makes that aspect of the case that much stronger. So, likewise, it might be time to review and revise consents where monitoring is going to be used. Informed consent, we kind of an adage in our world is you can't consent away life and limb. But that being said, if there's an informed discussion with a patient who is fully cognizant of their surroundings and able to consent, it's yet another way to bolster the strength of a prospective medical legal case. And I know from experience with physicians that many of you can kind of get a sense or a feeling for which patients of yours may end up being plaintiffs. And so having this belt and suspenders of revised consents that include intraoperative monitoring and descriptive operative reports when you make that decision on what you're going to use or not use will be, I think, a big help to a prospective medical legal case and lessen the likelihood of that case ending up in litigation. And then finally, and this, I cannot recommend this highly enough, is to stay up to date on current guidelines and recommendations. Those don't supplant your reasonable judgments, clinical judgments, because those are what are setting the standard of care within your operating room, within your own practice. So with that, I appreciate your time. This is a QR code for our website and my direct contact information. I would welcome any of you to contact me directly to discuss this or any other medical legal questions you might have. This is something I'm passionate about and enjoy doing. So please feel free to do that. Thank you.
Thanks so much, Paul. Sincerely appreciate the talk. All the talks are great. You know, I'm not sure if it's going to alter the way I do things, but all the talks are great. I don't see any questions in the Q&A box, but if there are any questions, please enter them there. I guess I'll start by asking Dom and Mike. My impression, correct me if I'm wrong, is that Dom, you occasionally use neuromonitoring. Mike, you pretty much routinely use neuromonitoring. Is that accurate?
No. If we're kind of done with our role-playing part of this debate, I was texting or chatting with Dom. I actually agree a lot with his position. If I can be frank with my answers on the survey, I don't use it at all for decompression. I do use it routinely for lumbar fusion, but not because I feel like I need it at this point. Just more living in Chicago, the medical legal environment is different. So I was one of those who answers primarily for medical legal convenience, and it doesn't slow me down. It's available, and it just, if it were slowing me down and adding time and morbidity, then I wouldn't use it, but it doesn't, so I just use it.
And Dom, how about you?
Yeah, I almost never use neuromonitoring. I'll use it for cord level deformities. So if I'm doing a cervical thoracic deformity, I'll use it for that. But otherwise, I don't use it for thoracolumbar deformity, like a tendineum or degenerative lumbar cases.
So I guess one of the questions is, when you routinely use something, it creates a certain flow and a certain vibe with the anesthesiologist, as you guys talked about. Time is an issue, can delay cases, and also communication with the anesthesiologist is critical in getting accurate neuromonitoring. So what are your thoughts about routinely using it so you can improve that accuracy as opposed to occasionally using it? I mean, when I first started using O-arm, I used it once in a blue moon, and it would take 40 minutes for the spin. And the more you use it, the more it becomes just like a routine part of your case. So I'd like to hear both your thoughts on that.
Yeah. So sorry, Mike, I'll start here since I started talking, but I think that's a really, really good point. And a big reason that my neuromonitoring is the way it is just kind of when in Rome. At my institution, we all do it sort of the same way. And much to Mike's point about his case about that far lateral disc, when I first started and we were doing like posterior cervicals, we do a lot of posterior cervicals. I like to use neuromonitoring at first, right? Because I was a little bit nervous about the positioning. Somebody's really stenotic. Am I flexing them too much? Am I extending them too much, et cetera, et cetera. And that was a wall that was really hard to push against, right? Because no one else did it. So it would add an hour to my case every time I did it, no matter how often I did that, right? Because there's 9 of us at the clinic. And so I stopped using it for that because I just don't think there was any way to get around the fact that it would just never become routine. And so I do think that plays a big role in it.
Yeah, definitely. It has become routine for me, so it doesn't really add much in the way of cases. And I'll say every now and then I'll look at these AP X-ray and say, that looks a little bit funny. Why don't we just test it? And then it'll all be in place for me to test it. But that doesn't happen very often. So yeah, you're right, Rock. If it's a matter of routine, then you can kind of get into your flow and it doesn't really slow you down. There is the added cost. I mean, that's undeniable. Yeah. I guess one more thing that I'll add is that, Paul, I really appreciate your talk and in the sense, in your frank opinion, but I don't want any medical legal attention at all. So you're talking about defending cases and winning cases. I mean, that's good and all, but I don't even go to that realm. I don't want someone to do that to me, and I have to sit for a deposition and think about this and deal with it. And I mean, honestly, that's probably the main reason why I use it, because I don't even want to. I mean, Chicago's maybe a different landscape than other parts of the country. So I think well, I don't want to speak I'll speak for myself. It's not a matter of do I think I can defend it. It's a matter of do I want to have any of my bandwidth devoted towards dealing with this, So that's the main reason why it's neuromonitoring.
And I think that makes a lot of sense. Maybe it's particularly for you, you're in Chicago and Cook County, and that is by far one of the busiest dockets of anywhere in the country. They're in actually Miami-Dade. Those are the two busiest dockets of anywhere in the country.
Awesome.
So yeah, congratulations. If you want to move, you're welcome in Detroit. Your point about not wanting to deal with it. I mean, you went to medical school to treat patients, to care for patients, and being distracted by those medical legal implications is an unfortunate reality. And so I don't mean to be all doom and gloom and say that, I probably am more risk averse in many ways because of what I do, because I only see the negative outcomes. I only see this pooling of only the bad things that happen in hospitals. No one calls me when things go right at the hospital. So if it's a question of yes or no, again, it comes down to comfortability and what your tolerances are, what your risk aversion is in that situation. But I don't think that there's anybody that's hunting down Michael Lee's charts looking for did he or did he not use neuromonitoring.
Just a quick follow-up question, and then we'll switch to Q&As for really all three of you. Mike and Dom, does your decision to use neuromonitoring change if a patient has cord compression or pre-existing neurological symptoms? And for you, Paul, the cases maybe you came across or seen were those patients having some of those pre-existing risk factors where neuromonitoring might have helped?
I'll go first then. So in short, yes. I mean, the very fact that they're coming in for a surgery of some sort or a procedure of some sort, they're going to have a deficit. Conservative management has failed them to that point, and they are, by and large, they are out of necessity. And so those situations, maybe it's a concentration bias when I look at it that way, that because these patients are coming with pre-existing issues, and therefore hopefully remediation of those issues, they are going to be at a higher need for neuromonitoring. So through that lens, yes, I mean, I think it leans that way in my opinion.
Yeah, to answer your question on whether they have pre-existing cord compression, the way I decide what to use neuromonitoring for is I always think, is there anything that I can do to make a difference if I'm using neuromonitoring, right? So if you take somebody with, like you're doing an ACDF on that has cord compression, well, if you hit the cord and you have a neuromonitoring change, there's nothing you can do about that. It's done, right? If you're doing a surgery and you're worried about positioning, right? They have an spiny fracture, you're worried about positioning. Well, then maybe that's a really good, that's where I would use neuromonitoring, right? Because I could change something if I needed to. So I don't necessarily know about their pre-existing condition. I just think whether or not I can change something in surgery. If I do a lot of cord manipulation because there's tumor everywhere, then I might use neuromonitoring because I know how much I can manipulate the cord, right? Or pull it over if I had to. So that's sort of my sort of stance on when I use it, if I feel like I can make a difference.
So Dom, do you genuinely feel that if you misplace a screw and you get radiculopathy afterwards, that repositioning the screw will not get rid of that radiculopathy? I mean, in the clinic you don't have that happen, but in Michigan it's happened to me, so I'm not exactly sure.
No, I mean, we've all had misplaced screws, right? I think the data suggests that, not necessarily will it change anything, at least according to the data, not necessarily will it change anything. I think, if we have a misplaced screw, you got to take somebody back to surgery. Of course you do that, right? Because you think it'll make a difference. I don't know that with the current sensitivities and specificity of triggered EMG, if it's really that good of a modality to know that you have a screw that's a little bit medial, and whether or not that screw is going to be symptomatic or not. And so we don't use routine neuromonitoring for lumbar cases, but I don't know that it would. I don't know that it would help you in the long run. At least the data would suggest that.
Zori, do you want to go through the panelist questions? I
Yeah.
have the Q&A questions.
Yeah, Mike, I didn't know if you wanted to add anything, but so the first, oh, sorry, go ahead, Mike.
I know it's okay. I mean, I basically agree with Don. I think if there's opportunity to change what you're going to do, particularly when dealing surgery on the spinal cord, whether it's deformity, corpectomy, I think if there's an opportunity to reverse whatever I did, then that's where the value of neuromonitoring comes in, particularly on cord country. But in the lumbar spine, it's obviously a lot more controversial.
Yeah. So the first question is from Flynn Rowan, thoughts on use of MMGs. Mike or Dom?
So to expose my ignorance, can you specify what you mean by MMG?
While he's typing that, we can go to the next question. Yeah.
Khalid, please clarify, is MEP used for cord level or for lumbar root level? I guess better than TEMG for root at lumbar level.
I guess I'll tackle that one because that's the study that I presented. So that last study of 4,000 patients was basically a proof of concept study that you could use MEPs for lumbar root issues during degenerative lumbar cases. And so it's hard for me to say one's better than the other, but at least in that study, they had demonstrated that there's a better sensitivity and specificity for picking up a neurological injury by using MEPs, even in the root level lumbar spine.
Thanks. Paul, a quick question for you from Ricardo Cortez. How detailed should you be in the off notes when a neuromonitoring event with a spinal suspected injury occurs? Is more necessarily better?
The short answer is yes. Being able to explain your thought process, the reasoning behind it, it puts you in a superior position should the case go to sue. The ability to describe why neuromonitoring was used, how the injury occurred, and remember that it's the standard of reasonableness. We're not expecting everything to be perfect. I mean, as Dominic just said, we've all had misplaced screws, or to paraphrase. And so it happens. These things happen. Each one of those statistics that we looked at today are tied to a real live human being that had an unfortunate event during their surgery. So in describing that in your operative note, being able to explain why it was used, your approach, and what occurred when the injury occurs, that puts you in a far superior position. So yes, I would say more is better in that situation.
Thank you. Sid Badwe, for Mike and Dom, do the panelists routinely perform pedicle screw stimulation in the lumbar spine?
No.
No.
And another question, if you get signal changes during a case and there is no obvious nerve damage and you're trying everything to reverse, but it doesn't improve, are you expected to stop the case, or would you be at fault to continue to proceed with surgery? I think this is a good question for everyone.
I think it depends on where you are in that case. If you're in a situation where the patient's spine is unstable, and you've done what a reasonable surgeon would have done to try and reverse any kind of potential damage, I think you achieve stability and close up, you elevate the maps, and then you kind of get to a point where where you can kind of abort or close safely. So I think it depends on where you are in that surgery, if the patient is stable enough to abort, if you're concerned about it. Now, bear in mind, there are always false negatives and false positives, and if you use your best judgment. But if it's something suspicious, like a 80%, 90% drop, and your neuromonitoring guy is saying, yeah, I think there's something real going on here, then I'm more inclined to listen versus kind of 25, 30% drop, not really sure one side, it came back, no, now it's going down again. You have to use your best judgment in those situations.
Okay, can I just clarify or just modify that question a little bit? So for cord level stuff, I mean, that's a different story. For For today's discussion, we're talking about routine lumbar degen cases. So if you can answer that question in the context of routine lumbar degen cases, you know, if you're doing like a TLIF and then you have, you know, your L5 nerve roots firing, EMGs firing actively, you've assessed your screw tracks, taking them out, they look good, you've done an O-arm spin, what do you do at that point in time? I think that that's a harder question to answer to a certain extent, and that's what this talk is going to focus on. So if you guys can explain that, that'd be great.
As long as there's nothing more can be done to ensure the safety of the nerve root, I think you try and finish up as expeditiously as possible. Yeah, but I mean, if you're doing it, let's say you're doing L2 to S1, maybe you kind of just don't do as many levels and just kind of, you know, do the main worst levels and try and get out if you want to see. But as long as you've done what a reasonably prudent surgeon would do in a situation to ensure nerve safety, I think I'll probably just finish up as quickly as I could.
Yeah, I agree with you, Mike. I think, you know, kind of thinking that through, and maybe Paul, you could shed some light on this, but I think you should continue that surgery, right? So if you're doing 4-5 TLIF and the L4 nerve root is lighting up like a Christmas tree on your EMG, and you've done an O-arm spin and the screws aren't medial or inferior, and you know you're not distracted, you're taking your distraction off, you're distracting, well then I think you should continue on and make sure that that L4 nerve root is decompressed. I would explore it, I would take the facet off, take the facet off for TLIF anyway, but I mean I would do whatever I could do to make sure that nerve root is decompressed, and then afterward I would say, you know, hey, yeah, you had the signal, but you know, your root is totally fine. I tracked that thing all the way down into the leg and it looks great. You know, obviously, you know, hyperbole there, but you get what I'm saying. I think you should continue.
I also think that, so an example of a TLIF, let's say if I'm getting a lot of EMG firing and I'm, you know, retracting that traversing nerve immediately, and I just can't get enough exposure for that TLIF, you know, I might just abort the TLIF and just do push lateral fusion. So I think that, I mean, that's a situation where you may just kind of modify your plan depending on where you are in the surgery. I mean, if it's after the cage or the bone graft is in, well, there's not much you can do about it at that point. You might as well take the benefit of the interbody fusion and then just hope for the best. But depending on where you are in the surgery.
And the law happens to agree with both of you that you should continue with the surgery if it can be done safely. You know, this is a perfect example of clinical decision-making and how that plays a role in the operating room, and why we can't be slaves to the idea of, we're going to follow this. Oh, we got to stop now. You have to adjust accordingly. You guys know this better than I do. You have to think on your feet. And so I think that's absolutely right. You continue with the surgery if it can be done safely and effectively.
There's another question that we have by Khalid Madni. Is a misplaced breech screw considered a complication or negligent if sued by a patient?
That's a very good question, Khalid. So that's exactly the type of case that I see in litigation. It is a complication. It's a known complication of procedures. It's something that I'm sure is included in your consents, but the fact that it happens and injury occurs, causes some injury, there's damages, that is likely to lead to a malpractice case where you are accused of negligence. That is true. But what happens during that malpractice case is that you will be afforded the opportunity to explain what happened in the OR during your deposition. You'll have experts that are retained through the insurance company that insures you that will testify on your behalf and say that the things that you did were reasonable, that you exercised sound clinical judgment and your actions were reasonable. And although you may have misplaced a screw and it caused a breach, it's not a violation of the standard of care because it happens. Again, if you're acting in a reasonable way, was it reasonable to place a screw there? Was there anatomy such that it would allow for screw placement there? All of those things will go into play and are very super fact specific to the patient. But I hope that answered your question. I think that the misplacement of a screw generally will be considered negligence, but it's still defensible as long as you're exercising reasonable care while you're operating the patient.
Paul, does it make a difference about how misplaced the screw is? I mean, violations, 1 to 2 millimeters are fairly routine, but if the entirety of the screw is in the spinal canal, that's not. Does that make any difference? Is that any consideration?
Yes, absolutely. I mean, if you're so far medial that that it's hard to contrive an idea of where you were even attempting to place the screw. Yes, that will play a big role in my assessment of the case evaluation from the beginning.
So I know we're running late on time, but I had one more question. We talked a lot about stimulating screws, and like both of you guys said, and myself included, I don't think I've ever stimmed a screw. But what we do a lot now is percutaneous fixation, and like you pointed out, Don, we use O-arm a lot. And navigation can be off, right? And you can't really verify when you're doing it posteriorly whether you're accurate or not based on surface landmarks. So it's often just blind reliance on navigation when you're percutaneously placing screws. So in those situations, what are your thoughts on using neuromonitoring?
I was thinking about this when you were actually talking, Mike, because you made the point on talking about it with MIS, and I think it might be a useful thing there. I guess I'm going to answer your question with a question kind of irritatingly. I think that it would be very difficult, let me know what you guys think, to know that if you're using triggered EMG, that you're getting all the way down that long tulip that comes up out of the skin to actually stimulate the shank of the screw to get an accurate reading. I think that would, and let me know what you guys think, I think that would be very challenging. And that's my question to you. Don't you think that would be challenging to do?
How about free run EMG and MEPs?
I think it's reasonable. I certainly think it's reasonable. I think the data would suggest that it's not all that sensitive nor specific for it, though.
Did you come across anything specifically in your lit search looking at percutaneous?
Not percutaneous, no, just in general for lumbar cases. That study of 4,000 cases, they had a pretty bad sensitivity for EMG.
I think for percutaneous it's tough because we're typically not exposed to the nerve root, and we're just stimulating the screw itself. So everything's in my mind, everything's relative to what the nerve root responds at. And I've had patients, we have some obese patients in Chicago, and I've had patients where the needles don't quite get close to the muscle as they would in someone else. So it requires more stimulation to kind of get that EMG response. So if your control is not at 2 milliamps, which it should be for most people, then the delta would be different. So if you have a screw that stimulates at 12 milliamps, that might be safe for one patient, but not safe for another, depending on what the control is at. If it was over 20, 25, it's probably okay. But it's something. But that's my concern with MIS, is it's not a complete triggered EMG assessment if that's the goal, but it's something.
Be interesting to look at rates of EMG triggering and intraoperative post-instrumentation spin, right? So if your EMG was triggered and then you get no arm spin, take a look to see where the screws are. It'd be interesting to look at that.
Look at JC Levesque's comment in the chat talking about their experience at Virginia Mason in Seattle. And it sounds like they got the whole hospital kind of to make a consensus statement that they support either way, either with or without, at the discretion of the surgeon. And I think large statements like that from larger organizations can be helpful, if they're ever in a situation like that, the individual surgeon. So I'm wondering if we as a society, I know AANS has made a statement, and there have been some other review articles, but maybe this is something that we as a society should make some kind of statement once we agreed upon one way or the other.
Yeah, I think this is a great way to conclude our session tonight. We are over time. Really, we would like to thank all of our panelists, speakers, and also attendees for a great talks and the discussion. And see you at the next webinar. Thank you all.
Thanks.